Thank you so much, Professor Samut. Welcome to everybody. I will just quickly share my slides and I'll be right with you. I hope that you can see the screen and hear me okay.
Yes, it's perfect. Thank you.
Perfect. So very warm welcome from my side as well. From Heidelberg, my name is Thomas Held. I look forward to speak to you about carbon ion therapy of adenoid cystic carcinoma. It'll be a focus on head and neck tumors, since that's my main area of research interest. And I thought it would be most interesting to you to hear about what I usually focus on. So I hope you enjoy the lecture. We will first look at the history a little bit about Heidelberg. It's this gentleman, Vincent Czerny, who's been very famous for creating the first interdisciplinary research structures in Heidelberg, focusing on oncology under one roof. So he was a famous surgeon, but also radiation oncologist, and the founding father of the German Cancer Research Center and many other institutions that followed. So under this structure, also our clinic developed, and it's quite a large radiation oncology facility in Germany. We treat around 4,000 patients every year, many of them with photon radiation, but around 60 patients or more daily also with particle therapy. And I'm mentioning this because there is the fact that HIT, which you have, I'm sure, heard a lot about at this point, is a fully integrated facility in the regular clinical routine in Heidelberg. So this offers a lot of opportunities to treat patients with, for example, combination concepts. We use the same immobilization devices, both for particle therapy and photon therapy. So we can easily treat patients with both modalities, and also there's more and more imaging being integrated in this workflow. So this will also, as you will see later, influences the kind of clinical trials that we perform here in Heidelberg, and also the kind of concepts that we follow. So before we dive into carbon ion therapy, I want to quickly mention some facts about proton therapy, since it's also standard for difficult to treat tumor entities like sinonasal cancers or also salivary gland tumors in many institutions. We've learned from proton therapy that there's a benefit, especially for unilateral tumors, so lateralized tumors, like you can see here, where we can really spare the contralateral side. And nonetheless, we have to be aware of the dose, the excess dose that might be applied to the skin. So this is an important fact. And so there's many concepts, as you might know, for patient selection. So you really have to try to select the patients that will benefit the most from particle therapy. So patients where the organs at risk are not directly in close proximity, so that they cannot really be spared with particles, but also not too far away, so that it would also be easily treatable with photons. So these are the patients that benefit the most, and it's been shown for many different sites, mostly, of course, large salivary glands. So there's many NTCP models and also some clinical data showing this wonderful path from 3D conformal radiation therapy to IMRT to intensity modulated proton therapy or particle therapy. And really, you can see how the mean dose really decreases by a significant amount. And this also is something that the patients actually feel with the clinical results. Another organ in the head and neck area that has been in a lot of focus within the last couple of years are the swallowing muscles. They are consisting mainly of the supraglottic larynx, but also the pharynx muscles at the back of the pharynx wall. And if they can be spared, if the mean dose can be reduced significantly under 50 Gray or even better, then the patients will benefit significantly. And this is also much more easy or better possible to do this with particle therapy. So once again, NTCP reductions, but also advantages regarding the toxicity rates. once again, having a look at the unilateral irradiation, so for typical salivary gland tumors like adenoid cystic carcinomas, there's really large dosimetric advantages. You can see, for example, for the brainstem or the spinal cord, there's differences with regard to the maximum dose between around 30 to 35 gray for the photon plants and about 1 gray in the max dose for the particle plants. Treatment plans. So this will offer also a lot more flexibility with regard to possible re-irradiation should there be necessity to treat tumor recurrence that will make problems or could make problems in the future. So also, once again, in this trial from Romasa et al. From the United States, there was a lot of reduction in the, for example, dysgeusia, but also mucositis or nausea in these patients. So not only NTCP advantages, but also real clinical benefits for these patients. Then there's these large meta-analysis for particle therapy, both for protons and for heavy ions with regard to sinonasal tumors that was published in the Lancet, and that could show that there is not only a significant benefit with regard to the local control, but also to the overall survival. So looking at the 5-year event rates, and this is in particular the case for heavy ion therapy. So due to the steep dose gradients and also the increased biological effectiveness, more or less for all different histologies. This was a mixed meta-analysis with any histology. There could be shown a real clinical benefit for the patients. So looking more at carbon ion radiation, here the outcome has been shown to be superior, in particular for adenoid cystic carcinoma, which was one of the first entities that was treated in Germany, in Darmstadt, even the previous institute before HIT, where much of the developments for particle therapy in Germany happened. But also, of course, there's a lot of data for melanoma and other salivary gland tumors, but also sinonasal tumors. And also the toxicity rates are quite favorable. There's an importance for re-radiotherapy for local recurrence. I will get to that at a later time point. And also, of course, the possibility to perform combination treatments. So due to the highly increased RBE, it's possible to combine carbon ion with photon plants, with photon radiation, for example, to treat the neck, and nonetheless give a carbon ion boost to the primary tumor. Then there's many developments in the research field, preclinical research, but also translational research. For example, of course, the comparison of the different models. I'm sure you've heard a lot about this topic already, but also using ARCs to treat head and neck cancers. However, these are techniques that are not yet ready for the clinical routine and are still being evaluated. So there's a lot of really impressive data available from Japan, from these large multi-center studies, typical with these hyperfractionated schedules, typically with 16 fractions. For these difficult to treat and complex localized adenoid cystic carcinomas, but also melanomas, and with really promising results. So only 17% late high-grade toxicity. Oftentimes, this is the case for visual impairment, so optic nerve damage on the ipsilateral side where the tumor is located. This is oftentimes not possible to do it any other way since the tumor is infiltrating around the optic nerve. But the local control rates and overall survival rates with these concepts are over 80% after 2 years, and it is possible to treat, like it is done as a standard in Japan, only the primary tumor location without treating the elective lymph nodes, since these are tumor entities, as you know, that have a risk for lymph node involvement if the imaging is negative of around maybe 10 to maximum of 15% with regard to the melanoma cases. In general, you can see here also that the local control is better for adenoid cystic carcinomas in comparison to other entities or mucosal melanoma, which are highly radiation resistant, even with particle therapy, therefore difficult to treat. So looking at salivary gland tumors, there are some established risk factors. For example, the histology, we know that adenoid cystic carcinomas belong to the most locally aggressive salivary gland tumors. Also, for example, the resection status or the kind of postoperative radiation therapy and also the radiation technique are highly associated with the outcome. And then there's many ongoing molecular factors that should be determined in these cases. For example, in particular, also non-adenoid cystic carcinomas, androgen receptors, so the hormonal receptors, but also HER2, so also yeah, possible targets for treatments with antibodies. This is in particular important for salivary duct carcinomas and also mucoepidermoid carcinomas, which are also quite frequent tumor entities of the major salivary glands. So here the TNM staging, which is from the NCCN guidelines for salivary gland tumors. And as we understand in the clinic, unfortunately, most of the tumors are actually T4 tumors since they are infiltrating to the skull base, usually with perineural spread along the nerves to the skull base at an early stage. So most of the tumors already at an advanced stage at diagnosis. Looking at the mutational status of adenoid cystic carcinoma is quite difficult to really find a driver mutation that is responsible and could be targeted. In fact, these are tumors that are highly methylated, and there's a whole diversity of different mutational profiles and also a really large heterogeneity between different tumor entities, which you can also see in the clinic. So there could be a adenoid cystic carcinoma that grows very slowly with a slow rate of growth of around maybe 5% Ki-67, but then there's other tumor entities that already after 3 months are spreading aggressively, metastasizing, and not only to the lung but also to other organs, which is then associated with a really a bad prognosis. So the same tumor entity, it seems, but the clinical impressions can be really severely different. This is also from the NCCN guidelines, the recommendations how to treat adenoid cystic carcinomas. They should be, the tumors should be resected as good as possible with good functional results. And the NCCN recommends postoperative radiation therapy for any adenoid cystic carcinoma. At our institute, we are a little bit more restrictive if it is only a PT1 or PT2 tumor without any other risk factors like perineural spread or high-grade component or things like that. Then we also offer the patient that it's possible to just perform imaging controls. But in the NCCN guidelines, radiotherapy is recommended at any time it is adenoid cystic carcinoma. At least to my knowledge, there's no real large data that is really had a look at these early stage tumors and the benefit of particle therapy for these early stage tumors. So it is still open for discussion whether to treat, for example, a T2 tumor without any other risk factors or perform surveillance, regular clinical and imaging surveillance. So then after the start of particle therapy around 2009 and also the implementation of the gantry, carbon-ion gantry 2012, first clinical data was published around 2015 on the first results of the comparison of carbon-ion boost combined with photon therapy, which has become the standard therapy at our institution, to the only IMRT or only IMRT treatment. And this not only significantly improved the local regional control from around 40 to 60% after 5 years, but also led to a significant overall survival benefit and therefore became the new standard of care at our institution. Moreover, the toxicity was quite good in these patients. There was no higher grade toxicity, no dose limiting toxicity with these concepts. And this is just a case example, a very large sinonasal adenoid cystic carcinoma of the minor salivary glands that extended to the orbit and was treated with definitive radiation therapy with a carbon ion boost. And it's typical to see even 3 months post treatment that there's still could still be some residual changes, and there's also not, of course, always a complete remission of the tumor that's being treated even directly after therapy, since oftentimes there's like a residual tissue that is hopefully then still nonetheless inactivated and not be able to lead to a recurrence in this case. So this was, of course, a favorable result regarding this complex initial situation. Of course, there's sometimes treatments that don't work this well, and therefore there's ongoing clinical trials to still further improve the situation for these patients. So then a couple of years later, the cohorts became larger, and from adenoid cystic carcinoma cases, also from the major salivary glands, but the results still were quite favorable regarding this difficult to treat tumor entity. So still sticking with these combination treatments with photon therapy and a carbon ion boost, usually 50 Gray to the neck and to the elective lymph nodes, and then a boost of 24 Gray. If the lymph nodes are involved, usually 56 Gray to the lymph nodes with a boost of 18 Gray and 3 Gray single dose with carbon ions. And you can see also the elective volume that is treated is usually quite small, much smaller than with, for example, squamous cell carcinoma. Nonetheless, the 5-year local control was even 80% in this evaluation, retrospective evaluation, and the toxicities of grade 3 were around 18%. So rather okay for this difficult to treat and situation with a high dose of around 80 Gray EQD2 cumulative dose. So then there were also different approaches, for example, to combine, since there's a couple of, to some extent, adenoid cystic carcinomas have alterations in the EGFR pathway. There was the attempt to combine radiation therapy with cetuximab, so a antibody against EGFR that we know from head and neck squamous cell carcinomas. It was done in a similar fashion compared to the Bonner trial. So with a loading dose and then weekly infusions and also up to 6 weeks or week 7 actually, and the toxicity rates were quite favorable. Nonetheless, there were a little bit higher rates of radiation dermatitis than expected. So grade 3 dermatitis of 22% and grade 2 of over 40%. So the trial didn't quite meet its predefined feasibility endpoint. It was also a small trial with only just a little bit over 20 patients. Nonetheless, the outcome was once again quite favorable, looking at the 4-year local control and overall survival. So in the range of the previous retrospective and prospective results from our clinic. So then there's the question, of course, maybe it's possible to increase the local control further, and coming from these data with a 5-year local control of around 60%. There's the comparison to the Japanese data that's having a control of around 70%, so possibly a little bit better. And also, of course, there's a neutron therapy data that's really offered quite a high local control, but there's other disadvantages that I'm sure you're aware of. So there's the aim to improve the control, since we also saw that most of the recurrences occurred in field in the boost area, even in the former gross tumor volume area. So the hypothesis was really of this new trial to improve the local control, and somehow possibly also in a similar fashion, but still different, like it's being done in Japan. So this is the so-called ACO trial, a randomized prospective trial for adenoid cystic carcinomas that is bound to recruit 306 patients in around 7 years. There's a standard therapy with a combined treatment, and then there's the carbon ion only treatment with 51 gray and 3 gray single dose, and then a boost of another 15 gray and 3 gray single dose. So you can see here once again, T2, T1 tumors are not primarily included in this trial, and the target volume concept has been highly standardized with geometric margins of around 6 to 9 millimeters for the boost, extending onto the GTV and along the perineural routes of spread even more. So in total, you will reach up to a 21 millimeters margin for the photon plans. So that's why, for example, along these skull base entry zones, these target volumes really highly extend. I'm aware that in other institutions, the skull base is completely included, or the area adjacent to the tumor is completely included. So also the perineural spreads, routes of spreads are of course always included. In this case, in this trial, also to standardize it, it was being done with a geometric concept. And there's also some cases like this nasopharyngeal adenoid cystic carcinoma, of course, once again, a favorable case that showed a really nice remission in the second follow-up after therapy. So also for function preservation, this is a really nice tool to use carbon ions. I'm aware that you probably won't hear the sound, but this is a patient that was treated due to laryngeal adenoid cystic carcinoma because she declined laryngectomy. She's a teacher, and she's was treated then with combined treatment, really had a really good functional result, even though the tumor was really a T4 tumor with extension to the surrounding tissue. So for this patient, this really worked out, and she was possible she could continue to work as a teacher and also with a really good voice preservation. So really good results in this case. Then there's, of course, the different radiobiological models that are being used also for treatment of adenoid cystic carcinoma, especially also for the head and neck area, highly relevant since there's many organs at risk in close proximity. And I don't want to go at all into detail with these different models. Nonetheless, one of the main differences is that the plateau region is calculated differently. So the dose with the low LET usually is a little bit overestimated with the LEM1 model. So especially for very large target volumes, the dose could be overestimated in the target volume. And therefore, it's sometimes interesting to recalculate with MMKM to understand if there are any differences in the coverage. So far, there's no real prospective data on a superiority of any of these two models. I think they both have advantages and disadvantages, but it is for sure a very good idea to look at these models in comparison and understand more what are the clinical benefits and the clinical differences. And there's, of course, some really nice data already available for adenoid cystic carcinoma that has been published in 2019, where the researchers learned that most of the recurrences actually occurred in field once again, so not due to inadequate target volume delineation, and most of them were actually due to sparing of the organs at risk. So as we know, for example, the contralateral optic nerve, we try to spare it as best as possible. There's tumor volume right next to it. And in these dose gradients, typically the recurrences occur most frequently. So in this context, also it's highly important if there's a model that will evaluate, a dose calculation model that will evaluate this plateau dose differently, and for example, possibly enable a higher or steeper dose gradient next to organs risk at risk. This could potentially influence also the local control. So that's why it's also important to look at these factors. And this group even adjusted the dose constraints due to these dosimetric differences. Neutrons, of course, not a standard at all. I think there's just one institute in Seattle that offers neutron therapy still for head and neck cancer patients, for very selected patients. It was performed also at the German Cancer Research Center for some years, and neutron therapy could yield a really, really good local control in these patients. However, of course, there's severe side effects, especially fibrosis, long-term fibrosis, late tissue reactions. So that's why this is not at all a standard anymore and not recommended. So here's a short overview of HIT and especially the focus on the carbon ion gantry. We try to understand, well, which patients do we actually treat with carbon ions only and at the gantry, which is one of the questions we try to answer here. And first of all, we could see it's a whole variety. It's a very heterogeneous group, and there's a large proportion of head and neck cancers with different tumor entities. And the toxicity, if there's no chemotherapy being given simultaneously, is rather low, with only 4% higher grade toxicities. And so far, over 1,000 patients have been evaluated in the database that were treated this way. What came a little bit surprising is that around 1/3 of the patients, at least in the last years, received re-irradiation with the carbon ion gantry. So this facility is being used to a significant amount to re-irradiate patients. So a very complex situation, and this situation has been increasing since 2012 continuously. So it's a situation there. There's, of course, local recurrence is still a large problem in the head and neck area, and usually salvage resection is the first option that is being evaluated. If it's not possible, re-radiotherapy can be offered. Nonetheless, with photon therapy, there's a high toxicity rate of around 80%, higher grade toxicities, even up to 10% mortality. In these studies, the authors try to overcome radiation resistance by using alternated fractionations or also combining with chemotherapy. This was too toxic for the patients and actually probably also even shortened the lives of the patients. And this is due to the fact that we always, of course, try to reach the optimal point in this therapeutic window and try to get to exactly this point where we have the highest chance of cure with the lowest complication probabilities. However, if there's a prior radiotherapy, there's no therapeutic window. We cannot just continue to treat, of course. We have to wait for some recovery. We have to use modern techniques like heavy ion therapy and also adjust or adapt the dose and the volume in particular, treat with smaller volumes. And possibly then the patients could reach a situation like this where a second chance of cure is possible. So there's many previous studies on re-radiotherapy. For example, this trial on photon therapy for nasopharyngeal tumor recurrence that yielded toxicity rates of around 40% higher grade toxicities. So in the re-radiation setting, only the higher grade toxicities really count because there's not many alternatives, and it is not really worthwhile to worry about grade 1 or grade 2 toxicities when thinking about performing salvage treatments like this. For proton therapy, the toxicity rates seem to be a little bit lower. However, one has to be careful that radiation dermatitis rates can be quite high and even higher than with IMRT, at least in the region that is directly over the tumor region. And also carbon ions with another improvement of around 20% higher grade toxicities. And this is also something that we could find in our own data. We looked at around 230 patients, most of them with adenoid cystic carcinoma recurrences. The interval between the first radiotherapy treatment and the second one was at around 4 years, and the dose applied was 51 gray in 3 gray single dose. So the total dose in average was around 130 gray EQD2. So you can see the outcome was much better for adenoid cystic carcinoma than compared to head and neck squamous cell carcinomas. And nonetheless, it's really important to perform individual patient selection. So the performance status has to be good enough. The localization has to be treatable. Salvage surgery should be evaluated. It's important what is the ongoing toxicity after the first treatment? Is there still severe toxicity, for example, like laryngeal edema that is then possibly even contraindicating another cause of radiotherapy, and what techniques to use? So the standard is IMRT, but also particle therapy should be evaluated. We could find that there was a dose correlation, so a dose of over 51 gray improved the local control, but the most important prognostic factor was the time interval. So if it was over 2 years between the last radiotherapy, these patient cohort had a significantly better prognosis. This is probably not only due because the patients have more time to recover from the initial course of therapy, but also since it is an indicator how aggressive the tumor entity is. If it occurs really early, it's probably biologically also a more aggressive tumor entity. So this is kind of a very easy to assess, but a very important prognostic factor. So it's of course all about dose limiting organs at risk. How much we can treat is only depending on the area, and most of all, these critical organs like the brainstem, the optic system, and the spinal cord. These are the main players in this equation. And from data from MD Anderson, we know that it's quite amazing how much a tissue is able to regenerate and recover after radiotherapy, so up to 70% recovery within 2 years. However, although there's a lot of clinical data now available on photon re-irradiation, it is not quite that easy with regard to particle re-irradiation, in particular for all the different combinations of previous photon radiotherapy with then carbon ion re-irradiation, or maybe previous proton therapy with carbon ions, or the other way around. So it is for these combinations still time to find out how the reactions are and what the optimal dose constraints are. We try to stay, compared to other institutions, I think, more on the conservative side, with only 20% extra cumulative dose that we allow for the critical organs at risk over an interval of 2 years. So there should be enough time to recover. And so far, with these constraints, we didn't experience any unexpected higher grade toxicities in these cases. One that is quite frequent is blood-brain barrier disruptions. For example, for skull-based tumors, 16% of the patients develop these lesions, only 3% are, however, higher grade. But there's quite a high latency, so these patients should be followed up at a regular interval for a long time at a specialized institution. And when treated early with the correct therapy, then there's usually a good clinical and radiological remission. We also initiated the CARE trial. It's a prospective randomized trial comparing carbon ions with IMRT for re-radiotherapy of head and neck cancer. And it is also accompanied by a large translational program, so performing tumor DNA analysis in the blood on a weekly basis. And as you can see, no chemotherapy, no elective treatments of the nodes, and very small margins are being used in order to reduce the risk for high-grade toxicities. From previous dosimetric comparisons, we know that even compared to proton therapy, carbon ions yield still much steeper dose gradients. It has, in particular, a smaller lateral scattering, and therefore improved lateral scattering, and therefore a smaller penumbra, and is even possible to usually, for all organs at risk, yield superior results compared to protons and photons. And this is also what we can see in our clinical cases. So even though the effective EQD2, the effective dose, was increased with carbon ions compared to photons, for all the organs at risk that were evaluated, the maximum dose and also the average dose could be significantly reduced with carbon ions. So there's ongoing evaluations, once again, with LEM compared to MMKM. and not only for the organs at risk, but also in particular also for the target volume coverage. And we also looked at the recurrences in the CARE trial that happened so far. Of course, these patients unfortunately develop recurrences rather early, since the median overall survival is around 12 months. It is a very vulnerable and difficult to treat patient cohort. Also, the target volume delineation is really complex because the tissue has so many changes from the previous surgical interventions and previous radiation treatment. Most of the patients had extraneous tumor recurrences, so outside of the radiation field. So this could be improved by improved imaging, for example. There were some part of the recurrences that occurred on the field border, so due to organs at risk, like the brainstem in this case. However, we could find that the coverage would not have been that much better with carbon ion therapy in this patient that was treated with photon therapy. So not every location is maybe clinically relevant superior with carbon ions. It also always depends on the individual situation. And then there's these infield recurrences, so where you expect that there's a biological resistance to radiation therapy. However, we also always perform MMKM recalculation and try to understand, for example, in this case, where the recurrence occurred here around this metal implant. It could be due to the inhomogeneities due to the metal implant. It could be due to just the biological aggressiveness of the tumor, but possibly also there were up to almost 10% dosimetric changes between MMKM and LEM1. So this is something where we really have a look at with the studies that is ongoing. So these are the 3 cases, once again, a little bit larger. Then I already told you that there's some tumor DNA being evaluated, and there's of course exciting data, for example, from University of California, San Francisco, where HPV DNA was evaluated, and we can now see that it usually correlates quite well with the tumor volume. It correlates well with the response, and also with the it's a good prediction factor to predict progression-free survival, especially if the patients develop a clearance after radiotherapy. So we try to do the same thing in a similar fashion. So far, we've only looked at the squamous cell carcinoma cohort, since it is a high shedding tumor entity, and evaluated around 100 samples that were treated either with carbon ion radiotherapy or photon reirradiation. We used a shallow whole genome sequencing and could find really good quality signals, so the typical dynamics. And I just want to show you some preliminary cases. We look at this just on a case basis. This is not something that we really understand yet. This is really important. It's just explorative, but for example, this patient with an esophageal tumor recurrence was treated with radiotherapy with photons, and responded really well locally, but had increasing tumor signal. Therefore, we also, since the patient was feeling worse, moved the staging a little bit earlier, and found that the patient then really had this increase until the chemotherapy was started, and then it was stabilized again. Another case, for example, here, patient treated with carbon ion reirradiation developed, unfortunately, a field border recurrence. So there was a spike after reirradiation until the salvage resection. Then the signal moved back down again. Not fully, however. Unfortunately, this patient also developed regional lymph node recurrence. There's also other interesting factors. For example, this spike that you can see, these 2 patients were treated with carbon ions. Is it due to carbon ion radiotherapy, or is it just a coincidence? We try to standardize the time point at which we draw the blood from the patient, but we still don't know if the carbon ion therapy is possibly causing here more increase in the beginning of the therapy. Also, another interesting fact is to look at the fragmentation of these tumor DNA samples in the blood. We also want to understand if maybe the fragmentation could be higher after treatment with carbon ions compared with photons. Now we are moving more and more away from the current clinical trials and more looking at what's ongoing with regard to the future outlook. Just to show you some trials that are happening at our institution, for example, for these immobilization devices that are individualized for the patients with sinonasal tumors to move the tongue away of the high dose radiation field and really improve the sparing of the tongue, for example. This is quite a nice approach. Then there's ways to use imaging, in particular for adenoid cystic carcinoma, the so-called FAPI imaging, fibroblast-associated protein inhibitor imaging. And you can see directly in comparison to FDG PET, where you have, of course, the high signal from the brain. This FAPI PET yields a really nice signal without the surrounding noise, and can sometimes really help to understand the routes of spread, in particular also for perineural spread. So a really interesting tracer for adenoid cystic carcinoma. I don't want to go into too much detail here, but for example, another trial that we use for sinonasal cancers, in particular also minor salivary gland cancers, is this Navigator trial, so-called Navigator trial, where we try to find out after resection where the resection margins are really located. So you don't have to read, in this case, just from the report and try to think where could now these spots be where the surgeon took the samples. No, in this case, it's navigation based, and you can directly see where the samples were taken and if there's a R0 or R1 situation, and therefore if you could include it in the target volume boost or maybe not. Yeah, so also an interesting approach. And on the other hand, also we are trying to perform tuberorganoids and irradiate these as well. So far, it's possible for us to do it with squamous cell carcinoma, with adenoid cystic carcinoma. We are still struggling, trying to get there, but also hopefully in the future, this will be possible to understand some information about the radiation sensitivity of these patients. So I'm already at the end of the lecture. Thank you very much for the attention, and maybe if there's questions, I'm happy to discuss with you.
Thank you very much, Professor Held. We have one question on the Google Sheet. So ACC has a long survival time. Would treating oligometastatic disease with carbon SBRT make sense? What about PSMA for detection of early metastatic disease?
Yeah, very good question. So I think it always depends on the aggressiveness of the tumor entity. So we see a lot of patients where we have multiple lung metastases that occur maybe some years after the local therapy, and we just follow up these patients. We don't treat them at all. These lung metastases maybe grow 2-3 millimeters every year. And the patients don't have any impairments in quality of life or acute problems by this situation, despite, of course, the psychological problems that, of course, are there. Sometimes we decide after discussion in the tumor conference to treat maybe a single lung metastasis or a single liver metastasis with SBRT, but usually then with photon therapy, since it's also possible to really reach a very high dose. We try to stay away from resection of these metastases, in particular in the lung. We've seen very aggressive tumor progression after multiple lung resections, in particular with regard to the pleura. So we usually then rather recommend systemic therapy, for example, with axitinib, and try to reach a controlled situation where the tumor doesn't continually grow anymore. And then maybe if it's stable for some while and still there's only maybe 2 or 3 lesions, we sometimes refer the patient to the thoracic surgeons for resection, but then it's more in a controlled situation, and we don't see that often this diffuse spread along the pleura, which then usually is associated with also functional impairments. So to answer the questions, we've never performed SBRT in the lung, for example, for lung metastasis, sometimes for liver metastasis. It's not a standard. Usually we use photons for lung metastasis, SBRT, and also only for selected patients.
Okay, thank you very much for that very detailed answer. Do we have any other questions? I am not seeing any hands raised, nor am I seeing any questions in the chat. Okay. Professor Held, thank you very much. It was a very interesting lecture.
Thank you.
Thank you for being with us today.